Dr. Audrey Jung is a specialist in orthodontics and pediatrics and possesses an impressive CV. Briefly speaking, she earned a Doctor of Dental Surgery degree from Seoul National University and a second Doctor of Dental Surgery degree at UCLA, where she conducted extensive research in obstructive sleep apnea, OSA.
Dr. Jung teaches in several universities, including Stanford University, UCLA, and the University of the Pacific. She has introduced a pioneering technique performing maxillary distraction osteogenesis for the treatment of OSA, and also has published papers and co-authored chapters on the subject in several leading journals and textbooks. She recently founded the World Dental Facial Sleep Society, which will be having their first meeting here in Rio this coming October 2023.
Dr. Audrey Jung, in the last years you have been studying and applying the distraction osteogenesis maxillary expansion technique, or DOM, on your patients. What would be the main indications for DOM?
Distraction osteogenesis maxillary expansions was developed for OSA patients whose middle palatal sutures may not predictably expand non-surgically. So before I talk about the DOM, I need to talk about the MARPE first a little bit here. So MARPE is a technique that utilizes a mini screw with expanders, providing the greater force to split the middle palatal sutures and circumferential sutures. The mini screw are inserted next to the middle palatal suture line right below the nasal floor, which connect the expansion screw to parallel to the bone. So compared to regular expander, the additional anchorage from the mini screw provide advantage of minimizing dental alveolar bone tipping while the maximizing skeletal expansions. So MARPE was able to expand after middle palatal suture is mature. So we found that we are still able to open up the sutures for young adults or teenagers. However, MARPE does not always work, especially for the older populations. So we designed the DOM to have a more predictable palate expansion for older OSA populations. So DOM is designed for the patient who has a sleep disorder breathing or obstructive sleep apnea and also have a high arch palate with a nasal obstruction symptoms.
Still concerning the distraction osteogenesis maxillary expansion DOM technique, could you please briefly describe the technique?
Originally, we published the conventional DOM technique, and now we use more mini DOM or mind DOM. Mini DOM or mind DOM is not the small DOM. It's a less invasive technique using endoscopy. So when we talk about the conventional DOM technique, that is similar to conventional SARPE cut in addition to the MARPE. So after we deliver the MARPE, the surgeon perform a limited osteotomy at the LUFO 1 level without down fractures and pterygomaxillary disjunctions. But still the incision is made inside the mouth, and it's about the 1 centimeter incision in the both sides. And then for the maxillary middle palatal suture split, we use a piezo saw and using the wedges to open up the sutures, and you will see the maxillary central diastema immediately. Now we use the mini DOM technique, which is minimally invasive nasal endoscopic DOM to minimize the post-op discomfort. So the incision made through the nose, so there is no cut inside the mouth, and the endoscopy is inserted for the better visualization of anatomic structures. And we put the ultrasonic aspirator to use to create the osteotomy. When we did our study, we found that with the mind DOM, we get a significant reduction in discomfort, and because surgical cut of facial musculature is avoided. Now our team is to customize the MARPE for optimal implant and expander success. So we modify the osteotomy, and we also customize the MARPE based on the desired expansion. So for example, the patient does not want the large diastema from the DOM or mini DOM expansion, then we leave the piriform area intact. or if the patient want more posterior expansions, then we do pterygomaxillary disjunctions, but not necessarily we do the LUFO1 cut. So everything is actually customizable.
What are the main differences in the indications between MAR and DOM, and what is the impact of these techniques on obstructive sleep apnea?
The major difference in indications are the patient's age and sex and amount of expansion required. So the DOM, distraction osteogenesis maxillary expansion, is basically osteotomy in addition to the MARPE. So DOM is indicated when the MARPE alone is not expected to achieve a successful skeletal-palatal expansions. We found that females tend to have higher success for non-surgical expansion than men. Also, the older you are, the more difficult to get the skeletal expansions. So personally, if the patient is a woman and the amount of skeletal expansion is needed is reasonable, then I tend to use the MARPE until the around the age. If the patient is a man with a thick palatal bone and the patient require a lot of extensive palatal expansions, then I start recommending DOM a little bit early, maybe even the late 20s. And when you use either MARPE or DOM, once you achieve the skeletal expansion you want, it improves the nasal airway. So think about it. The palate is the roof of the mouth, but also flow of the nose. So palatal expansions increase the nasal flow width, increase the nasal volume, which decrease the air resistance through the nose. And also palatal expansions increase more tongue space, so tongue posture can come up and forward to open up the pharyngeal airway. And also it tightens the pharyngeal muscle to make the more airway less collapsible, which further improve the OSA.
How can orthodontic treatment contribute positively to improve OSA? What would be the main guidelines for orthodontists to not miss the diagnosis of patients with OSA?
Orthodontic treatment can indeed contribute positively to improve obstructive sleep apnea. Obstructive sleep apnea is often caused by airway collapse, and orthodontic treatment moves teeth, jaw, and tongue position, which are attached to the airway. Examples are palatal expanders, which make the maxilla wider, and or functional appliance to bring maxilla and the mandible forward. These appliances can help widen the airway and improve the breathing during sleeps. If our orthodontic treatment aims to move the teeth or jaw to create more airway positively or proper jaw growth and balance, OSA can be improved by better airflow and less collapsibility. In order not to miss the diagnosis of OSA as an orthodontist, a thorough medical history, screening, and clinical exams beyond the teeth, these are three things are important. Especially, I like to emphasize to say we need to pay attention to craniofacial growth pattern, especially for the kid. From infancy to adulthood, the dentition and craniofacial complex change with the growth pattern can be intercepted and targeted at the critical time point. As orthodontists, we can do meaningful interventions to improve the patient breathing and sleeps, especially the certain facial characteristics such as narrow high arch palate, retrognatic mandible, long face height need the special attentions. And another important key I like to mention is we need to collaborate with other healthcare professionals. I recently published the journal Sleep, a roadmap of craniofacial growth modification for children with a sleep disorder breathing and multidisciplinary care. This article proposed a clinical guideline for application of multidisciplinary care with emphasis on the dental facial interventions that target variable growth pattern. And before I finish, I like to invite all of the listeners, especially our Brazilian friend and colleague, to attend the World Sleep Meeting, which will be held in Rio this coming October 2023. This meeting is also be our first meeting of World Dental Facial Sleep Society, which I founded. So please join us to support the role of dentistry and orthodontics in sleep medicine. It will be an exciting and fun educational event. Thank you.
Dr. Audrey Jung, thank you for this interview and congratulations for your cutting-edge work.
To be in touch with Dr. Jung's work, visit www.draudreyjung.com.